Today on In Your Face Anatomy, we are learning all about the joints. Joints part 1. Good luck. All right, here we go with joints. So this is not a terribly complicated chapter, but we are going to break it down into 3 distinct sections just to make our lives a little bit easier, make it easier to facilitate the information. So what we're going to start with is just the classification of joints, the general information, the generic stuff. And then part 2, we're going to talk about range of motion. And then part 3, we are going to get into the different major joints of the body. So with that being said, let's get into it. Joints are also known as articulations. They get that name because when 2 bones come together, we say those bones articulate or touch. So articulations, aka joints. Some of their functions, they prevent bone growth. They permit bone growth for being possible. Permit parts of the skeleton to change shape during childbirth. There specifically, we're talking about the pelvis of the mother and the cranium or the skull of the infant. And they enable the body to move in response to skeletal muscle contractions. Our muscles have to attach to the bones, and when those muscles contract, the joints allow movement to occur. Now, there's 2 different ways that we can classify joints. This is the first way, and it's by how much movement the joint actually possesses. So this is the first way to classify joints, by how much movement. So we have three types. We've got synarthrotic joints, amphiarthrotic joints, and diarthrotic joints. So synarthrotic joints, these are joints that are considered immovable. You may be able to get like the tiniest amount of movement in there, but for the most part, these joints don't really move. And we see this in structures like your skull. We have those sutures that connect the frontal bone to the parietal bones, and those suture lines run in between them. Those are types of synarthritic joints. Really immovable. Then we have amphiarthrotic. These are joints where we can get a little bit of movement in there. And lastly, we have diarthritic joints. These are our freely movable joints. When you're thinking of joints, you're probably thinking of diarthritic joints. So that's the first way. The second way we can classify joints is by really what they're made of. So one, we got our fibrous joints. With this, we got dense connective tissue connecting the bones that make up that joint. So dense connective tissue, we're talking fibrous joints. We find this between bones that are in close contact or bones that are really close to each other. Our second way to classify joints is cartilaginous joints. So as the name would entail, these are joints that are composed primarily of cartilage. And specifically, we have one set made of hyaline cartilage and a second set made of fibrocartilage, and we'll get into that in just a moment. So cartilaginous joints made of cartilage, hyaline or fibro. And then lastly are the synovial joints. These are the most complex of the joints. They allow for free movement. This is most of the joints in the body are going to be synovial joints. This is for stuff like your shoulder and your hip and your elbow and your knee and your ankle. All of those are synovial joints. All right. So let's look at these joints coming back here. We're going to go through each of these categories. We're going to start with fibrous joints first. So with fibrous joints, there are really 3 different types of fibrous joints that we find in our body. We have a syndesmosis, a suture, and a gomphosis. So syndesmosis is defined as a sheet or bundle of fibrous tissue connecting the bones. I would know that definition. Anything that's bolded or italicized, underlined, anything that stands out in this PowerPoint, you better know. So syndesmosis, a sheet or bundle of fibrous tissue connecting the bones. We get a little bit of movement in here, so they're amphiarthrotic because of that slight movement. And our example for this one is the joint between the tibia and the fibula, which we have pictured there for us. We can see that syndesmosis joint. Our second type of fibrous joint is a suture. These are typically between flat bones. We find most of them in the skull. They're synarthrotic, so really no movement. So with our sutures, there are 4 sutures that I want you to be familiar with. I've got my coronal suture cutting across the top of the skull between the frontal bone and my parietal bones. I've got my sagittal suture, which we find just in between the left and right parietal bone. squamous suture between the parietal bone and the temporal bone. And then lastly, my lambdoid suture between the occipital bone and my parietal bones. Now, the coronal suture, I thought it was always pretty easy because this is the one where we think it's always a good time for a corona. And we point to the side of our head like we have got a bright idea because then we're literally pointing to that coronal suture. The sagittal suture, if we think back to chapter 1 when we were doing planes and cuts, we had a sagittal cut or a sagittal plane that goes right down the middle of your body and leaves you with a left and right half. The sagittal suture follows that line of thought, right down the middle of your body, and we're going to have a right and a left half with that sagittal suture. So the squamous suture and the lambdoid suture are the two that I would always get confused. The top two made sense to me. The bottom two I would always get confused until I started pretending that the red mark with the lambdoid suture we see in the bottom right, I would pretend that's an L. Yes, I know it's an upside down L and it's really more like a V, but I would pretend that's an L, so then that would get me to that's the one that's the lambdoid suture. And with the squamous suture, I would close my eyes and squint, and I would pretend that was an S for squamous. It doesn't look anything like an S. I know. But you know what? It also looks absolutely nothing like an L. There's no way I'm looking at that squamous suture and thinking, oh, that's an L. No, absolutely not. That's the lambdoid suture on the other side. But so that's how we remember those. All of these pictures are fair game for the practical exam on this chapter, so make sure we're absolutely familiar with our sutures. And then our last type of fibrous joint, super easy, is called a gomphosis. So a gomphosis is defined as a cone-shaped bony process in a socket. So our example of this is a tooth in a jawbone, and that's as complicated as I'm going to get with a gomphosis. You need to know a gomphosis is a type of fibrous joint, and you need to think of a tooth in a jawbone, or tooth in a socket is what you need to think of with a gomphosis. Excuse me. Our second type of joints are cartilaginous joints. And again, we said we've got hyaline or fibrocartilage. We have two types of cartilaginous joints, a synchondrosis. Remember, chond in the middle there is our Latin for cartilage, so that automatically tells us, as soon as we see that CHOND, that this is a cartilaginous joint because it has cartilage in its name, just in Latin, synchondrosis. And then the other one is a symphysis, which you've already looked at a little bit with bones, but here we are back with a symphysis to explain on that a little bit further. So what we want to know about these two, first is the synchondrosis joints, bands of hyaline cartilage. That's the association I want you to make. Synchondrosis equals hyaline cartilage. That's what we're finding in between the bones, uniting this joint or holding all of this joint together. Synchondrosis, hyaline cartilage. A lot of these are temporary joints. We get these between the manubrium and the first rib as our example here. Our second type is a symphysis joint. Symphysis cartilaginous joint to be specific. These are pads of fibrocartilage. Fibrocartilage. So remember, synchondrosis, hyaline cartilage, symphysis, fibrocartilage in between the bones. We want to be that specific. So symphysis equals fibrocartilage. We got the pubic symphysis as one of our examples that we learned in bones. And we also have intervertebral discs, better known as IVDs. Each intervertebral disc is composed of an annulus fibrosus that surrounds a gelatinous core called the nucleus pulposus. So I like to think of cartilaginous joints, specifically, I like to think of intervertebral discs as like jelly donuts. That's what you need to think of with an intervertebral disc. The outer layer, the part that would be the donut itself, that's called the annulus fibrosus. And it surrounds that gelatinous core, which would be the jelly inside of that donut, called the nucleus pulposus. So the donut is the annulus. The jelly inside the donut is the nucleus. And so when people end up with conditions like sciatica or, the lumbago, the low back pain, that is super common, it's because part of that disc, specifically the nucleus of that disc, is pushed out where the annulus has been weakened or just degraded over time, or it's been injured. And so that disc, the nucleus gets pushed out of the disc, and it starts to hit a nerve just a little bit. But just a little bit is enough to cause that pain to run down your leg that we associate with sciatica, or the pain in your lumbar spine or in your low back that we associate with lumbago. So let's be very familiar with the intervertebral discs. We want to know that there are symphysis joints, and symphysis are types of cartilaginous joints specifically made of fibrocartilage. And me just being a chiropractor, I love to ask about intervertebral discs, so make sure you know your stuff on that. And then our last type of joint is a synovial joint. Like I said earlier, this is most of the joints in our skeletal system or in our body. They're diarthrotic, so lots of movement. And so we're going to go into detail here about the different parts that we associate with a synovial joint. This is what we're going to talk about pretty much the rest of the time are going to be synovial joints. So this is a picture of just a generic made-up joint. This is not a real joint in the body, but we just made up a joint here so we can see the different components that we associate with a synovial joint. So we got articular cartilage, the joint cavity, joint capsule, synovial membrane, synovial fluid, meniscus, and bursa. And we're going to talk about these in detail right now. So we're going to start with articular cartilage. That's our first component of a synovial joint, and it covers the end of the bones that are making up that joint, or the ends of articulating bones. The bones that come together to form this joint, the ends of those bones on each end is covered in this shiny, super strong white material. And you can see that in our picture. And what that does is it resists wear and tear, and it minimizes friction on the joint itself, because we don't want the bones degrading, and then we're rubbing bone on bone, because that's going to be painful for everybody involved. So we use this articular cartilage to help give extra strength to the ends of the bone so they don't erode away just with daily usage and wear and tear. And you can see this next time you're eating like a chicken leg. If you bite the top of the chicken leg off, where I'll get all that meat off there, you'll be able to see the articular cartilage shiny and white on the end of that bone. It's going to be on both ends of that chicken leg. So articular cartilage, shiny white, end of the bones, resist wear and tear, minimizes friction. The next component of a synovial joint is the joint capsule, aka the articular capsule. And we have two layers that we separate here for the joint capsule. First, I've got the outer layer of the joint capsule, and this completely encloses the other parts of the joint. And we can see in our picture how it attaches to both bones in this joint, and it completely wraps around all the other structures of the joint. So it's really important in helping hold the bones together that make this joint. It attaches to the periosteum of each bone, so it's up past the end of the bone. We're onto the neck area, kind of, not that far. It's flexible to allow movement, but it is strong enough to prevent separation. So it gives us some movement and keeps it from pulling apart. That's the outer layer of my joint capsule. The inner layer of my joint capsule consists of a shiny vascular lining of loose connective tissue we call the synovial membrane. We can see that in the dark blue outline surrounding the inner parts of our joint. That dark blue outline is the synovial membrane, aka the inner layer of the joint capsule or articular capsule. Now, my synovial membrane, only just a few cells thick, covers all the surfaces within the joint capsule except anything that's already covered by articular cartilage. Articular cartilage is already there to do its job, so we don't want to put a synovial membrane on top of that, because that's not going to help anybody. So my synovial membrane surrounds a closed sac we call the synovial cavity. So that's just the space in between the dark blue lines we call the synovial cavity, into which the membrane secretes a clear fluid we call synovial fluid. So that's synovial fluid in the light blue area here. That's going to be filled with that liquid. The synovial membrane also helps reabsorb fluid, which is super important if the joint becomes injured or infected. The purpose of synovial fluid is to moisten and lubricate the joint so we are able to move easily, and it helps supply the articular cartilage with its nutrients. So it feeds the articular cartilage and it lubricates the joint. That's what the synovial fluid actually does for us. Now, if someone does come in to see you and they have some sort of joint pain, knee pain, super common, shoulder pain we see a lot of, one of the first things we do is we aspirate the joint itself. We stick a needle in there and we pull out a sample of that synovial fluid. Now we want to know that normal synovial fluid has 180 or less white blood cells. Arthrocentesis is the actual act of sticking the needle in and pulling out a sample. And then the very first thing we do with that sample is we look at it. We want to look at it, see what it looks like, because that might point us in the right direction. So when we look at it, if the fluid appears bloody and has a lipid layer on top, so it's bloody in coloration, but it has a little fatty layer floating on top, that's going to be indicative of a fracture. One of the joints, or one of the bones coming into this joint, has a fracture in it somewhere, and it may be like a hairline fracture, something that we didn't see or something that we missed on plain films or radiographs, and so we'll be able to pick it up if we aspirate some of that synovial fluid. So fracture, if it's bloody and has a lipid layer on top. If the fluid is clear but has a raised stem cell count when we run some lab work on it, then that's going to be indicative of OA or osteoarthritis. OA, osteoarthritis. When we look at it, if it's cloudy and yellowish, that's going to think. Then we're going to think RA or rheumatoid arthritis. If we look at that fluid under a microscope and we see crystals have formed in the fluid, then that's going to be indicative of gout or gouty arthritis. If it's cloudy but it just has a slight red tinge to it, we're going to think something bacterial is going on in this joint. And as always, if we get an increased white blood cell count, we're going to think infection. Anytime we have a raised white blood cell count in the body, we're going to think infection. So for the written test, I could say make a diagnosis if you think, if you aspirate a joint and the fluid appears cloudy and yellowish. What's your diagnosis? Or I could show you a picture of bloody fluid with a lipid layer floating on top and ask for a diagnosis on the practical exam, and you'd have to tell me that's a fracture. So two different ways you'll see these questions on both the written test and the practical exam. Now, ligaments reinforce the joint capsule. They just help strengthen the joint, is what they do. They help bind articulating ends of bones together. They help prevent excessive movement at the joint. Ligaments are typically inelastic, so there's not a lot of stretch to your ligaments. That's why we tear ligaments. And they tighten when the joint is stressed. Menisci, though, little discs of fibrocartilage. So we're back to fibrocartilage again. Little discs of fibrocartilage that completely or partially divide a joint into compartments. They help cushion articular surfaces like little pillows between the bones, and they help distribute the body weight. And so we can see that the only time we're going to talk about menisci is in the knee, and when we get there. It's one of the first things we talk about. But we can see in our picture right in the middle, in between my femur and my tibia, I've got these meniscus set up, or these menisci. And then if we look at it from the top-down view here, you can kind of see how they come in and help distribute that body weight is what they do. They allow separation between the bones, so we're not rubbing bone on bone, and they help distribute body weight. That is the importance of menisci. Bursa, little sacs filled with synovial fluid. We typically find them between the skin and something bony. Their job is to cushion and to help aid in the movement of tendons from muscles over bony parts. So when we're moving our arm around or our leg around, we have these bursa set up to help the tendons of the muscles that are attached to the bones slide over the joint, so they're not getting snagged up on any of the processes sticking out of the bones in that joint. Now, the good thing about bursa is their name pretty much tells you where they're at. And we'll get into that here. We got bursa in the shoulder and the knee coming up. More on that when we get there. Let's just remember that the name of the bursa indicate their position. Little synovial fluid-filled sacs. So we have a few different types of synovial joints to talk about. And like we said, it's most joints in the body, so we have to separate them out into categories. So what I want you to know for this part specifically, you got to tell me the name of the joint, you got to tell me the AKA of the joint, and you got to tell me what makes that joint special, or that type of joint special. What makes it different from the other joints that we're going to talk about. So we got 6 different types of synovial joints to look at here. The first one, really easy one, ball and socket joint. Ball and socket joint is also known as a spheroidal joint. So when I see this, I see sphere first thing. Sphere is a ball or a round object. Round, ball and socket, sphere, ball and socket. I make that association. So this is always an easy one to get to. Now it consists of the bone with a globular head that articulates with the cup-shaped cavity of another bone. What makes it different, what makes it special, is my ball and socket joints have the widest range of motion compared to all of my synovial joints. So really all the joints, period, ball and socket joints have the widest range of motion. If you think about how you can swing your arm in all different directions, that is because it is a ball and socket joint. Next up we have a condylar joint, also known as an ellipsoidal joint. We get these between our metacarpals and the phalange bones. We got the ovoid condyle of one bone fitting into the elliptical cavity of another bone. So what makes this one special, what makes this one different, rotation is not possible. You're not able to rotate the bones or the digits or whatever in a condylar, aka ellipsoidal joint. Next up we have a plane joint. Plane joints are also known as gliding joints. I always remember this because I think of a plane gliding through the air, plane joint and gliding joint. Articular surfaces are flat or slightly curved. We get these between our carpals and our tarsal bone, so the bones in our wrist and our foot. And this is our SI joints as well, our sacroiliac joints, where your sacrum meets your ilia bone in your pelvis, the SI joints. Those are also plane joints or gliding joints. So these are typically going to be flat bones that slide past each other. They kind of just glide past each other. That is a plane joint or a gliding joint. Hinge joint, also known as a hinge joint. Convex surface of one bone fits into the concave surface of another. What makes hinge joints special? They permit movement in one plane only. You can only really do one thing with a hinge joint. It's only going to bend in one direction. So we see this with our elbow, specifically with the ulna of our elbow, and our fingers as well are going to be hinge joints. You know, you can flex and extend your finger, but that's all you can really do with those digits. The pivot joint, aka the trochoid joint, the cylindrical surface of one bone rotates in a ring formed by a bone and a ligament. We see this specifically between C1 and C2. So we got atlas on top of axis, so we're able to get that rotation movement with our head. So what we want to know with the pivot joint, movement is limited to rotation. Limited to rotation. Now, how I remember the pivot joint or the trochoid joint's a little out there, but just bear with me. Because of our example of this is atlas and axis, C1 and C2, I always think of you want to choke them in the trochoid. Choke them in the trochoid. And you kind of grab the top of your neck there. Choke them in the trochoid. Because that's going to let me remember C1, C2 is what we're talking about. And as soon as I think C1, C2, I'm thinking, oh, rotation. So movement is limited to only rotation. It's the only thing we can do at a pivot or a trochoid joint. And then we have the saddle joint. Saddle joints are also known as sellar joints. Forms between bones whose articulating surfaces have both concave and convex regions. So the surface of one bone fits into the complementary surface of another. What makes it special? It permits a variety of movements, mainly in two planes. We find this between the thumb and that first metacarpal. So a couple things about the saddle joint. This one you kind of already know because in the skeletal system, the chapter we just did, we talked about inside the skull we have the sella turcica, the Turkish saddle, where our pituitary gland sits. Sella turcica, Turkish saddle joint, aka sellar joint. So sellar is just saddle in Latin. Now, when the next two bullets, we talk about forms between bones who have both concave and convex regions, and it fits into the complementary surface of another bone. What you need to think of with saddle joints or cellar joints is they fit together like puzzle pieces, where it's going to fit perfectly into that complementary bone. And we already said it permits movement in two planes only. So that's where we're going to end part 1. Come back for range of motion in a minute, but lots of good stuff here. Tons of good test questions. So I would definitely get a handle on this before you move on. Good luck.